Now we discuss another important topic, which is infarction. An infarct is an area of ischemic necrosis caused by occlusion of either arterial blood supply or the venous drainage in a particular tissue. This process is called infarction. For example, myocardial infarct, cerebral infarct, pulmonary infarct, bowel infarction, gangrene, then septic thromboemboli, infected thrombi, for example, valvular vegetations in bacterial endocarditis, infarcts become infected by bacteria and transforms into an abscess. Tumour emboli does not cause infarcts. Foreign body infarcts are seen in IV drug users. Cholesterol, atherosclerotic plaques. Consequences of infarction depends upon the nature of blood supply, rate of development of the occlusion, vulnerability of tissue to hypoxia, blood oxygen content in anemic patient. Etiology: thrombotic or embolic arterial occlusion, vasospasm, expansion of atheroma or hemorrhage into atheroma, extrinsic vessel compression by tumor, torsion of vessel, for example, in testicular torsion or in intestinal volvulus, traumatic rupture or vascular compromise by edema, for example, in anterior compartment syndrome, entrapment of the artery in a hernial sac. Pathogenesis: the process of infarction takes place as follows. Localized hyperemia due to local anoxaemia occurs immediately after obstruction of the blood supply. Then, within a few hours, the affected part becomes swollen due to edema and hemorrhage. The amount of hemorrhage is variable, being more marked in the lungs and spleen and less extensive in the kidneys and heart. Cellular changes such as cloudy swelling and degeneration appear early, while death of the cells, that is necrosis, occurs in 12 to 48 hours. There is progressive proteolysis of the necrotic tissue and there is lysis of the red cells, and an acute inflammatory reaction and hyperemia appear at the time in the surrounding tissues in response to the products of proteolysis. Blood pigments, hematopoietin and hemosiderin, liberated by the lysis of RBCs and deposited in the infarct. At this stage, most of the infarct become pale gray due to loss of red cells. Following this, there is progressive ingrowth of granulation tissue from the margin of the infarct so that eventually the infarct is replaced by a fibrous scar. Dystrophic calcification may sometimes occur. Classification of infarcts according to color: red infarct, white infarct according to infection, septic infarct, bland infarct according to age, they are fresh or they are old. Now there are certain clinical correlations, factors influencing development of infarct. Number one, nature of blood supply, that is end-artery blood supply, which is seen in spleen and kidneys, dual blood supply seen in lung, liver and hands, rate of development of occlusion, atherosclerosis of coronary arteries is gradual, slow process, and role of collateral circulation, that is slowly occluded vessels become organized with alternate perfusion pathways of collateral circulation. Venous thrombosis can cause infarction. The most common outcome is just congestion. Bypass channels rapidly open and permit vascular outflow, which then improves arterial inflow. Infarcts caused by venous thrombosis are more likely in organs with a single afferent vein, for example, in testes and ovary. Red or hemorrhagic infarct resulting from venous occlusion seen in loose tissue where blood can collect in the infarcted zone, for example lung. Dual circulation allow flow of blood from an unobstructed parallel supply into a necrotic zone, for example lung and small intestine. When blood flow is re-established in a previously occluded blood vessel or in a tissue where there is a congestion. In previously congested tissue by sluggish venous outflow, re-establish flow site of previous arterial occlusion and necrosis following angioplasty of an arterial obstruction. There are hemosiderin macrophages. These red infarcts are firm and brown with time. White infarct or anemic infarct occur with arterial occlusions in solid organs with end-artery circulation, for example heart, spleen and kidney, where tissue density limits the seepage of blood from adjoining capillary beds into the necrotic area, more pale and sharply defined with time. Grossly, they are wedge-shaped occlude vessel at the apex. Periphery of the organ forms the base. When the base is a serosal surface, there can be an overlying fibrinous exudate. Fresh infarcts are poorly defined and slightly hemorrhagic. In old infarcts, margins tend to become better defined by a narrow rim of congestion which is attributed to inflammation and due to release of chemical mediators. Infarcts resulting from arterial occlusions in organs without a dual blood supply typically become progressively paler and more sharply defined with time. In lung, hemorrhage infarcts are the rule. Now this photograph is taken from textbook of Robbins, 8th edition. There is a hemorrhagic infarct of the lung which is roughly demarcated and wedge-shaped, whereas on the other side of the photograph there is white infarct which is sharply defined and is present in the spleen. Septic infarct following fragmentation of bacterial vegetation from a heart valve or following microbes seeding a necrotic area. It is converted into an abscess. There is greater inflammatory response and then scarring. Microscopy, there is ischemic coagulative necrosis, scar tissue formation, and in brain there is liquefactive necrosis. The microscopic features of septic infarct include bacterial vegetations, microbes seed the necrotic area, and there is abscess formation. This photograph again is taken from a textbook of pathology by Robbins, in which infarction has been shown, which is replaced by fibrous scar. Now, this is the photograph showing histological features of infarction. You can hardly find the tissue details of various structures. Again, the infarcted tissue showing the presence of inflammatory cells. Infarction in the spleen. Infarction of many internal organ leads to a pale infarct with a wedge-shaped gross appearance, conical in 3 dimensions from occlusion of a branching blood supply. There is splenic infarct in a patient with infective endocarditis. Portion of the vegetations have embolized to the spleen. These infarcts are typical of ischemic infarcts. They are based on the capsule, pale and wedge-shaped. The remaining splenic parenchyma appears dark red. Infarction of kidney. This is typical pattern with ischemia and infarction, that is loss of blood supply and resistant tissue anoxia. Here there is a wedge-shaped pale area of coagulative necrosis, which is infarction in the renal cortex of the kidney. Microscopically, the renal cortex has undergone anoxic injury at the left so that the cells appear pale and ghost-like. There is a hemorrhagic zone in the middle where the cells are dying or have not quite died, and then normal renal parenchyma at the far right. Now, this chart is taken from a book of pathology by Goljan, which shows differences between red infarct and white infarcts. Cause: in case of red infarct, arterial occlusion is present in loose tissues or organs with dual blood supply. Venous occlusion in ovarian torsion. White infarcts, arterial occlusion in solid organs with end-arterial circulation. Affected organs in red infarcts are lungs and small intestine, whereas in white infarcts, solid organs like heart, spleen, and kidney. Properties: in red infarcts, they are ill-defined hemorrhagic margins, which later on becomes brown, whereas white infarcts, there are well-defined margins which progressively becomes paler as time passes. Edema is usually present in red infarcts, whereas edema is usually absent in white infarcts. Now, just for your practice purpose, a few MCQs. A 45-year-old woman following major abdominal surgery has had discomfort and swelling of her left leg for the past week. On physical examination, the leg is slightly difficult to move, and on palpation, there is tenderness. A Doppler sonogram shows thrombosis of deep left leg veins. Which of the following mechanism is most likely to contribute to her condition? A. Hypercalcemia. B. Immobilization. C. Ingestion of aspirin. D. Nitric oxide release. E. Turbulent blood flow. As I told you that in MCQs you choose your answer by exclusion. So the most suitable answer you have to select. Now, calcium is a cofactor in the coagulation pathway, but an increase in the calcium level has minimal effect on the coagulation process. Now we come to immobilization. This is the important cause of venous thrombosis, and it often occurs with immobilization. Aspirin inhibits platelet function and it limits the thrombosis. Nitric oxide release leads to vasodilatation and inhibit platelet aggregation. Turbulent blood flow may promote thrombosis, but this risk factor is more common in fast-flowing arterial circulation. So, after discussing that, what comes in your mind? I think the most suitable answer in this case is immobilization. Now another question. A 28-year-old woman with a 15-year history of recurrent thrombosis from a prothrombin gene mutation develops septicemia after a urinary tract infection with Pseudomonas aeruginosa. She develops multiple infarcts and organ failure over the next 2 years. Which of the following organs is most likely to be spared from the effects of ischemic injury in this woman? A. Brain, B. Heart, C. Kidney, D. Liver, E. Spleen. Now let's choose the answer. Infarction of brain causes liquefactive necrosis, whereas infarction of various solid parenchymal organs, which are kidney, heart, spleen, they show coagulative necrosis and are due to emboli from the left heart often go to these organs. The liver has a dual blood supply with a hepatic circulation and a portal venous circulation. So this is the organ which is spared among all the other organs and can withstand ischemic injury when compared with other organs present in the list. So the answer is liver. Then another question. An 85-year-old man falls in the bathtub and strikes the back of the head. Over the next 24 hours, he becomes unconscious. A head CT scan shows an accumulation of fluid beneath the dura, compressing the left cerebral hemisphere. Which of the following terms best describes this collection of fluid? A. Congestion, B. Ecchymosis, C. Hematoma, D. Petechiae, E. Purpura. Now regarding congestion, it occurs when there is pooling of venous blood within an organ due to vascular dilation. Ecchymosis are blotchy areas of hemorrhage beneath the skin, serosal surface, or mucous membranes from a contusion. Petechiae are 1 to 2 millimeter pinpoint areas of hemorrhage. Purpura is hemorrhagic spots on the skin, mucous surface or mucous membrane which are larger than 3 millimeter in size. So this patient has a subdural hematoma from traumatic injury causing tearing of cerebral vessels. A hematoma is a collection of blood in a potential space or within tissue, and this is causing pressure. So we conclude that the answer is hematoma. Then another question. A 32-year-old man is involved in a motor car accident and sustains fractures of the right femur and tibia and the left humerus. The fractures are stabilized surgically. He is in stable condition for 2 days, but then suddenly becomes severely dyspneic. Which of the following complications from his injuries is most likely to cause of his sudden respiratory difficulty? A. Cardiac tamponade. B. Fat embolism. C. Pulmonary edema. D. Pulmonary infarction. E. Right hemothorax. I think if you concentrate, the answer is very simple, provided you have read the subject thoroughly. So, coming back to the question, cardiac tamponade and right hemothorax, they are immediate complications after traumatic injury and not delayed events. Pulmonary edema, severe enough to cause dyspnea, which would be unlikely to occur in hospitalized patients because they are closely monitored. Pulmonary infarction may cause dyspnea, but pulmonary thromboembolism from deep vein thrombosis is typically a complication of a longer hospitalization. The mechanism for fat embolism is unknown. In particular, why the onset of symptom is delayed for 1 to 3 days after the initial injury, or maybe up to 1 week for cerebral symptoms. Maybe the cumulative effect of many small fat globules filling the peripheral pulmonary arteries is the same as one large pulmonary thromboembolus. So the answer in this case is fat embolism. Now, dear students, I have discussed the subject of infarction and few MCQs relating to hemodynamics. If you have got any doubt regarding the subject of infarction or attempting these MCQs, please do write in the comment box, and inshallah I will answer that.